Good morning or hello. This is Stefan Paul from Zurich, Switzerland, talking to you today about the topic Restorative Excellence. Do implant restorations compare to restorations on natural teeth? A presentation given during the AAID conference 207 in Las Vegas. It's a pleasure to share part of this lecture with you today. And if you are interested in the full lecture, then you may go back to the homepage of Dental XP and find more about it. First question we have to ask ourselves is, what is restorative excellence and how do we achieve it? There are some key parameters, and I would kindly ask you to refer to the full lecture in order to get to those key parameters. In the present shortcut of that presentation, however, I'd like to proceed to the first chapter in that presentation that deals with single anterior tooth restorations versus restorations that are implant supported. Is it possible in such conditions to achieve restorative excellence? Here we have a first clinical case. Tooth number 8 needs a crown and post procedure. In detail, we can see here that we have a horizontal fracture line and a composite built-up so far as a first part of the treatment. The radiograph shows you the root canal treatment that has been performed previously, and then a glass fiber post was used to do a composite build-up. Impression taking, temporization, and then a week later we have a soft tissue healing that shows us a nice and healthy tissue, and then a non-ceramic restoration was fabricated. We check the emergence profile with the adjacent to natural tooth, also the occlusal aspect, the vertical, the buccal contour of that restoration compared to the natural adjacent central incisor. This is the situation right after adhesive cementation, where the soft tissues, of course, are not in a perfect situation yet. And this is the final result some 2 to 3 weeks later, where now, besides a very satisfactory white aesthetics, we also have a nice scallop of the soft tissues, stippling the restored tooth, very comparable to what we have on the natural tooth. So far for a restoration on a natural tooth. And here you have the palatal view, and then finally the x-rays before post placement at the time of placing a glass fiber post with a composite built-up, and the last x-ray was taken after the final restoration has been luted adhesively, just to make sure that we don't have any excess in the interproximal area and that we can verify our perfect marginal fit. So if we switch now to an implant placement situation, you're all familiar with all these measurements that usually we deal with when we try to achieve restorative excellence. Contact point area 5 millimeters to the bone knee crest, and the Tarno paper that everybody is very familiar with. Now, if we place an implant, we have some data from the literature telling us what to do and where to place that implant. Number one is the proximity to the natural root surface, which is 1.5 millimeters. And if we were to place a second implant, there's another paper by Dennis Tarno showing us that we should, whenever possible, aim at an inter-implant distance of some 3 millimeters. Last but not least, there's the 2 to 3 millimeter vertical positioning rule. Means the top of the flat ending implant should be some 2 to 3 millimeters deeper into the hard tissue compared to the zenith point or soft tissue zenith of the adjacent tooth. Now, if that is true for flat-ending implants, then what we are aiming at clinically, taking such an implant with, nowadays most implants have a rough surface to the nick of the implant. This is where the bone then would be, and if we add the soft tissue, this is where we measure our 2 to 3 millimeters below adjacent soft tissue zenith point or CEG, depending which one is the one to use. Now, this puts us into a trouble with respect to the bone in the interproximal area. Usually, if we place a flat-ending implant in this way, then we are too deep with respect to the bone in the interproximal area, and the result of this seems to be the bone loss that we will then see on the X-ray 1 year later. That brings the bone down to the first thread. Now, trying to improve that approach, if we respect data available from the literature, first question that arises is success rates in immediate versus healed sites. And there we can find some evidence that implant placement is successful in immediate sites as well as in healed sites with similar success rate levels. When it comes to aesthetic parameters, I would like to refer to John Coyce's paper published in 2004 that refers to tooth position, scallop, periodontium, biotype, tooth shape, and of course osseous crest, which means the 3D position. Timing and bone-to-implant gap. There is some evidence in the literature that implant placement as soon as possible after tooth extraction is favorable in order to preserve our alveolar bone. It means to minimize the resorption process. And last but not least, there is the Botticelli group that published data. What should we do with the bone-to-implant gap? And they report that if that gap is 1.5 millimeters or less, then no bone replacement material, such as bios, for instance, should be introduced into that gap. Just leave it as it is, and that is what my clinical experience usually is. If it is 1.5 to 2 millimeters even, usually on the buccal aspect, then I would just place the implant and not use any bone replacement material. Now, this clinical picture shows you the first Noble Perfect implant that I placed, but from today's perspective, I placed it too deep, which then resulted in that soft tissue recession, as you can see it here. My belief today is that this is a result just of the fact that the implant was placed too deep. Particularly the scallop-shaped design asks for an implant placement that is much more shallow. And if we again look into the literature, there's Dennis Tanner's group again, where they reported a 1 millimeter gingival recession after 1 year in 80% of all the implants they examined, using either Noble Biocare, Straumann, Stryker, or Interpore. However, what needs to be considered is that in this paper they were using no flapless approach, but they always would do a crestal incision, open up the bone, suture it back, and then do a second stage approach. So with this setup, they would find that 1 millimeter gingival recession. If we furthermore consider papers published by John Kahn and Peter Worley about flapless implant placement and immediate provisionalization, there's some indication that probably we get less recession, soft tissue recession, if we use that regimen. And that corresponds exactly to what I have been finding in most of my cases. And based on another final study I would like to refer to, published by German Galocci from the University of Geneva, where they examined on natural teeth the height of the scallop in natural teeth, means the two yellow lines. They found that in central incisors the scallop is some 3.5 millimeters high, and then lateral incisor it's only 3 millimeters, and decreasing little by little the more we come to the posterior teeth. Noble perfect implant in particular, that idea has been translated into that scallop shape that we see here, and the way I am placing my Noble perfect implants today is I'm aiming at the height of the interproximal bone crest being level with the tip of the microgrooves. Means we have a 1.5 millimeter distance of the implant that is sticking out of the bone compared to the interproximal bone height, and then the soft tissue is coming on top of that at 1.5 plus millimeters. Remember that the interproximal soft tissue height can be 1.5 till 3 millimeters of papilla height on top of that bone. This is a clinical case I would like to share with you today where I used exactly that technique I just described. A trauma case. This is the traumatic occlusion where the patient is not able to bite together anymore. And this is then the next day when we extracted the tooth and placed a perfect implant in an immediate approach, very shallow positioning with the bony crest level with the tip of the microgrooves, and a temporary restoration was integrated at the very end of that same procedure with a concave contour all around that emergence profile of the temporary restoration. That aspect, I'd like to emphasize, is very important for the soft tissue healing on the long run. So how does that look like clinically? This is the situation right after implant placement. This is what we get 1 week post-implant placement, and this is then the final situation 6 months post-implant placement, where we were able to maintain and probably even let the soft tissue contour, particularly when it comes to those papillae on the mesial and distal aspect. Very healthy situation. In the occlusal aspect, we haven't lost almost anything of the buccal contour, and now we are in this position to take an individualized impression with a standard impression coping, individualized that soft tissue emergence profile, which reflects exactly the shape the temporary restoration would have. And then the lab technician is in the position to fabricate a restoration. We used an all-ceramic restoration in this situation on top of a titanium abutment that was opacified to help to get rid of that grayish color that would shine through the all-ceramic restoration. And then here you see the clinical setup at the time of final delivery, adhesive cementation of that all-ceramic restoration on top of that opacified titanium abutment. The final smile, and then the clinical situation where, yes, we still have a little bit of grayish discoloration in the marginal tissues. However, we had that to begin with, since that tooth, that restoration or that tooth had a root canal treatment for some 10 years prior to the fracture of the tooth. So no changement in that, and the improvement we could see in the future is having all ceramic implants that may help us to get rid even of that little grayish discoloration. However, comparing the soft tissue levels with respect to zenith point and to papilla tips, we really were able to achieve a clinical result that is very remarkable and meets aesthetic needs in every respect. The little statistics I have been able to do so far with my with this type of surgical approach is such that Since 2003, we were able to place some 32 Noble Perfect implants in the various diameters, 5 in the mandible, 27 in the maxilla. And if we now look at the recession at the zenith point and papilla, then we can report that in 31 out of that 32 implants placed, we were not seeing any soft tissue recession, except for the one that I showed you, where we found that 1.2 millimeter soft tissue recession. However, we believe that this is due to the fact that that implant was placed too deep into the bone. When it comes to bone level, how that reacts over time, radiographically at least, the bone level is very stable. And if we get some bone modulation over time, starting with the bony crest being at the tip of the microgrooves and approximately, the maximum we see is that we get bone loss down to the bottom of that cup of the implant, but never further than that, which then I believe is one of the basis for that soft tissue result that I was able to present. The total, or the whole lecture will deal with additional multiple anterior teeth and implant clinical situations, and with full mouth reconstructions either on implants and teeth. You will be welcome to watch those procedures in the full-length presentation. For now, it's my pleasure to have shared those ideas with you. Thank you very much for your kind attention, and hope to have made you interested in seeing more of these results. Thank you very much.